So I moved to my last presentation. So VNS surgical procedure and how we do in our center. So VNS refers to vagal nerve stimulation, and usually this used as a palliative treatment for refractory epilepsy. In our setup, I have more experience in pediatric. That's how I start. This is just to recap our hospital in Kuala Lumpur, and this is our adult wing. And just across the road, we have our pediatric wing. We started our epilepsy surgery actually in 2013. We start with temporal lobectomy for mesial hippocampus sclerosis and lesionectomy. So once we have a good result, we have found that our angle classification seizure-free grade 1 about 96% on the first series. Then we start to embark on more complex procedure like hemispirotomy, disconnective surgery, and also VNS in 2018. So we have a multidisciplinary team approach again. We have a group of actually a neurologist, pediatric neurologist who went to Melbourne and in Excellent Center of Epilepsy, trained by Simon Harvey and Virginia Maxner. So then he came back and he said, let's start the epilepsy surgery. Okay, so we had somebody who really interested to do that. So this is how we start VNS implantation in 2018. So we done by now we have done almost 50 cases, including an adult. So but the numbers are being reduced during COVID, now picking up again. And of course we have this multidisciplinary approach. I visited Korea to learn a little bit about this technique. So we also now moving and join the adult group. So in our data, about 600 children with epilepsy occur a year, and almost 50% of them are more than one anti-epileptic medication. And drug-resistant epilepsy occur up to 30% of cases. And we know that the surgical treatment include resection, disconnective surgery, and neuromodulation vagal nerve stimulation, able to reduce the rate of seizure. And of course, the seizure outcome better for resective surgery with additional MRI. So vagus nerve stimulation therapy refers to a device that we can use to prevent or reduce seizure. So it sends regular small pulses of electrical energy to the brain via the vagus nerve in the neck. So it can be programmed to send a stimulation at regular interval. And the new model 106, even they can preempt when the heart rate increase prior to the seizure, so they can increase the stimulation automatically. So this is like a very intelligent kind of a generator which is currently used. So VNS therapy also used together with other medication. It is not just VNS alone. So indication, usually this is based on American guideline, adult or children 4 years and older. But in our series, we even use in 3 years old child who had a poorly controlled seizure. Even some seizure occur about 100 times a day. So despite 4 or 5 medication with side effect, so we got no choice, we intervene early. So patients usually have focal partial seizure that are not controlled after trying at least 2 seizure medication and not able to have epilepsy surgery for some reason. Either after workout, it is not what they call it conclusive, or at least the indication must underwent a thorough evaluation through a comprehensive discussion. It is not just, okay, go for a VNS. He has to undergo some thorough investigation first. However, there are few cases of which they are not probably suitable for VNS, especially when patients who have one vagus nerve, because the vagus nerve control your heart, receiving other concurrent form of brain stimulation, let's say patient on DBS, heart arrhythmia or other heart abnormality, dysautonomia, lung disease or disorder with shortness of breath and asthma, because this can have one of the side effects after vagus nerve stimulation. So we don't want the patient to have a double problem. So patient with gastric duodenal ulcer, because this can also stimulate all this, and patient who have vasovagal syncopal or pre-existing hoarseness, because some patient, once we start the stimulation, they have a voice changes. So the VNS has 2 parts. One is the stimulator or the generator, which we implanted on the left side of the chest. And then you have thin wire or lead that connected to the generator, and then it goes up and loop around the vagus nerve. So the anatomy of the VNS, he has three parts. The first, there is like a thread, colored green and two green, which is the anchor on the lower part. And then the other one is the negative. And then the positive one, which is in the middle, have a white suture. So we use this as a guide to know whether this is positive lead or negative lead and whether it is anchor. Anchor have not much purpose, just to sit, to make sure that the system sit there. And the active electrode is actually the positive and the negative. So it has many components that before you implant, you need to learn about it, because each one have a different roles. And then this is actually Aspire 106. Now we have implanted about 27, if not mistaken. So you can see green. So this is the anchor, and white positive, and then green negative. Yeah. And then in the earlier experience, we asked, they give us a dummy so that we have some understanding how big the incision should be. Okay. And when you wrap the vagus nerve, you must understand that this is actually not a complete ring. So the contact on the red is the one that really have some impulse generation that stimulate the vagus nerve. So in order to do that, you must remove the soft tissue around that, but you must preserve the epineurum, because you can have a vasa nervorum that supply the vagus nerve. If you remove the vasa nervorum, then the vagus nerve become ischemic. So you need to maintain that, so that you have to clean, but not to remove the vasa nervorum. So, and again, when you put, because sometimes when the patient move, and this electrode can move, so you have this, what I call it, make a U-turn, relieving band, and then it goes up and it go down again. Yeah. So this is how it looks like. And the technique involve 12 step. So the most important thing is to familiar. I usually come from the right side of the patient. So what you can see is actually from the surgeon view. Yeah. So I used to mark the sternomastoid. I will show you later. In the line of the incision, I make a horizontal incision, and I use about 2 finger breadths below the clavicle on the left side. So you only implant vagus nerve on the left, not on the right. There are few reasons, because right vagus supply the SA node, and left vagus nerve supply the AV node. If you don't want to interfere with the SA node, and of course you can avoid it if you put the lead at a certain part of the vagus nerve, and you have to put it below the left inferior cervical cardiac branch. So you can see here, so this is the vagus nerve, and this is inferior cervical cardiac branch. You don't want this to stimulate this, because they can have effect, arrhythmia to the heart. And if you look at this location compared to the thyroid cartilage, so if you can make incision along that, so then you can expose this segment nicely. Yeah, because the lead itself length about 3 centimeter, and one size fits for all. Even you use in a small children or adult, you need about 3 centimeter long length of vagus nerve, because the system can't fix here. So I use omohyoid, which is here, superior belly or omohyoid, as my key landmark muscle, so that I can retake it, because once you find that, it's quite easy for you to get the carotid sheet, then you can find the groove between ICA and in the vein, in the big vein, so that you can find the vagus nerve. So some describe you measure halfway between the medium notch to the submental area, and halfway. But I found this can be very confusing, because most important thing, I prefer to find the thyroid cartilage and lower part, and that's where the omohyoid cross. Okay, so this is again just a view and surgeon view like that. And just to recap back, The first layer, you will find the platysma. So I elevate the skin platysma. I make a horizontal incision, and then I will cut like 2/3 here and 1/3 over the sternomastoid and raise the skin platysma, because you can retract it easily after that. Then I will identify the omohyoid. Some people use just a loop, but I prefer to use microscope because I can see it clearly and my assistant can see it clearly. So this is the omohyoid. Then we put a loop and we track upward. So, and then you start to see the internal jugular vein. And this is after we open part of the carotid sheath. And this is the internal carotid artery. So the vagus nerve usually lies in between the groove. But we have seen cases where the vagus nerve lies on top of the ICA, just beneath the carotid sheath. If you're not careful enough, you may cut the vagus nerve. We also find the vagus nerve beneath the ICA, yeah, and sometimes beneath the IJV. So you have to be very careful about the variation. It can be confusing, especially in children, because the vagus nerve can be very small. Okay, so this is how after we skeletonize it, and try to use a different color loop like this, everything same. If your assistant wrongly pull, so they may pull the vagus nerve instead of the muscle. Yeah, so we make sure that we use a yellow loop usually for the nerve, and you must make sure that you have 3 centimeter length, because for the anchor, positive, negative, and you make a pocket another 1 centimeter below for the relieving band. Otherwise, if it is you don't have a relieving band, so the vagus nerve can be kinked because of the lead itself has a memory. So once we have identified that, I usually tunnel from capillate to the pocket below that. And before I tunnel, I make the subcutaneous pocket on the chest. And quite important for you to differentiate between man, a boy and girl. We have to do below the breast fat, yeah, not in the breast fat. So just above the pectoralis major muscles. So where you create a pocket and make sure that the pocket is able to accommodate your generator. So then once we tunnel, we pull out the thread, the lead, okay, like that. Okay, this is the critical part, because if you need to know the how the coil works. Yeah? So what I do, I use so you try not to crush on the lead, but you hold the suture, because the suture can, as you pull the suture, so you can shred it up and you can wrap around the vagus nerve. So I use this technique, use a blunt hook, yeah, and then we loop around. We hold the suture, yeah, here, and then we pull another one. Then subsequently, you can loop, and this is the anchor. We bring down, and here we have a loop relieving band down there, and then the second one, and followed by the third one. And having this omohyoid, you pull, you can get another 1 centimeter. This is very crucial in children, because in adult you have white space, but in children, this omohyoid, if you release it, you can get another 1 centimeter. Because if you couldn't get enough length, then you will end up in trouble, because you will not be able to put the electrode accordingly. Sorry. So then you have to anchor like that, okay, and then one loop there, second loop there, and then it goes down to the chest, yeah, like that. So this is a relieving band, and you have to connect this, and then you make another pocket, so that you loosely put the lead, because this is standard length. I think about 90 centimeter, regardless of the age. So in children, it can be very long. So you have to make sure that you have enough space, and be careful when you do revision. So I've done our first revision, and turned out to be this lead, even though it's very strong, it's covered by like a plastic sheet. But after 8 years, so it become very friable. So during the during the incision, it can easily cut. The lead can be very friable, and you have to change both. So then you connect to the generator, like that. So there are certain guidelines that you must pass through the tip of the generator of the connector here, and then you have to click thrice, 3 times. Then you do pre-programming so that the system are connecting with the generator. Okay, and then you set up, you interrogate the system, and then if everything okay, and then you start to fix it on the chest. Okay, and then they will start to on again second test before we close the skin. Okay, in our center, we just test on, and then we try to look at the heart rate. And because this is 106, it will read the heart rate. If the heart rate of the patient same with what is detected in the system, mean you have done a good job. So then we off immediately the system. Then we only started it 2 weeks later in the clinic. Yeah, so there are cases where we continue stimulation immediate post-op. They develop hoarseness of voice, some coughing non-stop and so on. So from then we decided that we give time for a while before we start it. So then you put the pocket, yeah, and then we second interrogation, yeah, and then subsequently this is how we do. We do on-table stimulation set at 0.25 and gradually increase to 0.5 to 0.5 before discharge, yeah, and then post-op. So we look at the data analysis slightly. Majority of our cases in children actually, because I start in children, about 11 to 15 years old, and the indication Lennox-Gastaut syndrome is the highest, followed by others as you see in the list. This is example of Lennox-Gastaut syndrome. A child 6 encephalitis in 6 months, had multiple seizure before, and then had multiple drop attack, and she had multiple scar on the face, on the limb, because of frequent fall, and because of frequent seizure. He had generalized discharge of EEG, and then we do a lot of workout. MRI shows unilateral gliosis, but the PET scan shows on the contralateral side involvement. So looks like you cannot really confine. So because the medication has failed, so we decided to put on VNF. We look at our first 20 cases. So at least about 80% have significant seizure reduction, about more than 50% in 30 case, in 6 cases. If you look at the quality of life also, they have improvement, those who receive vagal nerve stimulation. So complete seizure free, no aura in 5%, and then the outcome as you can see on the slide. So we have some complication. One child, he pull out the suture. So we have sometimes very difficult to control children. So we have to put back the stitch and have to put the child on glove so that you won't pull out the suture again. Okay, this is a case where you get infected but treated with antibiotic. So there are a few common side effects. What we can see majority, not majority, we have 2 cases hoarseness of voice. And then once we off and gradually we start back and it improve. And 1 case have severe cough. Immediately we stimulate. So we started with lower stimulation and gradually over a few weeks. Okay, so complication can be early, can be late, and then you can see as in the list. So in summary, the short-term seizure outcome of VNS implantation in our series is comparable to those who reported in established paper. So decision and choice of surgical intervention, especially in pediatric, require consensus of multidisciplinary epilepsy team. So important thing that you must make sure that the patient and family knows that this treatment is not curative. It is just palliative, and the objective at least to have a seizure reduction more than 50%. So the patient still on previous medication. In our experience, that those who receive VNS and the child has so significant improvement. So some, they refuse to learn and they become more reactive and more interactive after they start the VNS because the seizure frequency become less. So that's my end of presentation. Sorry. Thank you.